This is reducing and treating delirium in the gerontological population. Gerontological patients experience various health conditions, most of which impact their quality of life negatively. Delirium can impact the quality of life of older patients by increasing the length of hospital stays, leading to functional decline and nursing home placements, which are linked to poor health outcomes among older adults. Preventing delirium is crucial in this population. This conference presentation will use evidence-based research to educate nurses on identifying risk factors as well as signs and symptoms of delirium in hospitalized older adults. This conference will also discuss pharmacological and non-pharmacological methods that can be used to reduce delirium. Preventing delirium has shown to reduce the cost of healthcare and lead to better patient outcomes. The objectives of this presentation will include the introduction and definition. It will discuss risk factors of deliriums, list the signs and symptoms of deliriums, discuss assessment tools used for delirium, nursing interventions, non-pharmacological treatment of deliriums, pharmacological treatment and reducing risk, and then complications of delirium. Delirium is defined as a disturbance of consciousness with impaired attention and disorganized thinking or perceptual disturbance that develops acutely, has a fluctuating cause, and with evidence there is an underlying physiological or medical condition causing the disorder. Delirium is the most common complication of hospitalized older adults. Delirium is an unpleasant experience for the patient, increases fall risk, increases mortality, and increases hospital costs. Persistent delirium after discharge can cause depression, as well as long-term cognitive and functional decline. Research has shown delirium can be prevented in about 1/3 of patients by using a multi-component intervention plan. The risk factors for delirium in the older adult are vast and many. According to the Mayo Clinic, delirium occurs when the normal sending and receiving of signals in the brain become impaired. What causes this imbalance can be just one causing factor, or it could be a combination of several causes that allow for these mixed signals in the older adult brain. Among the most common risk factors for delirium in the older adult patient, especially while they are patients in the hospital setting, include but are not limited to certain medications or drug toxicity, a medical condition such as a stroke, heart attack, worsening lung or liver disease, or any injury from a fall, metabolic imbalances such as sodium or low calcium, UTI, pneumonia, or the flu. In addition to these common risk factors of older adults with delirium, hospital stays and surgery itself can be a risk factor for delirium. Also, according to the Mayo Clinic, any condition that results in a hospital stay, especially in intensive care or after surgery, increases the risk of delirium. And in the same study, the Mayo Clinic recognizes older adults as those most at risk of developing delirium. The link between delirium and surgical procedures in older adults is one that is still being studied in great depth to gain a better understanding of why postoperative delirium is so common amongst the older adult patient population. It is also a risk factor that many nurses may not associate with delirium. In one study that was conducted, it found that postoperative delirium occurs at a very high incidence among elderly patients following surgical treatment. No matter the risk factor associated with delirium, it is important to recognize them and implement early intervention, as delirium is often unrecognized or poorly understood and managed in hospitals. It is also important to recognize these risk factors, as delirium is unfortunately associated with high risk for adverse outcomes and is associated with a longer hospital stay, further cognitive decline, high morbidity and mortality rates, and a prolonged return to mobility. Signs and symptoms of delirium, just like its risk factors, are also very vast and wide and may not present the same in every patient, as the majority of the symptoms are situational. How the signs and symptoms of delirium are perceived and categorized also vary amongst different studies. According to studies performed by the Mayo Clinic, they group the signs and symptoms into different categories that include reduced awareness of the environment, poor thinking skill, and cognitive impairment, behavior changes, and emotional disturbances. Within those categories are the major signs and symptoms that are associated with delirium, which include but are not limited to hallucinations, restlessness, agitation, being withdrawn, anxiety, anger, depression, irritability, personality changes, disorientation, inability to stay focused, and difficulty speaking. Although these are common signs and symptoms in older adults, they are also common in older adults with delirium in the hospital setting. It is important to remember that these signs and symptoms can be associated along with a variety of other diagnoses. One of the hallmark differentiating signs and symptoms between delirium and other similar diagnoses, such as dementia, is that with delirium, It develops over a short period of time and fluctuates in severity. This simply means that one moment the patient may present as completely alert and orient to person, place, time, and situation, and the next they may be showing one of the many signs and symptoms of delirium. This may go back and forth, fluctuating between getting worse and then better until the delirium has resolved. Using assessment tools to help recognize delirium in older adults in the hospital setting can be a key factor in early detection or even prevention of delirium. However, across many studies, it was found that assessment tools for cognitive ability were rarely used, if at all, when trying to recognize the onset of delirium in older hospitalized adults. Therefore, this brings awareness to the need for more education concerning delirium assessment tools in the hospital setting. The following are a list of assessment tools suggested by the American Delirium Society that can be considered for use when trying to prevent and recognize early onset of delirium, and not just the older adult hospitalized population, but the hospitalized population in general. The first assessment tool is the Confusion Assessment Method, or Confusion Assessment Method ICU. This tool is an evidence-based, multi-component, interprofessional method of improving delirium assessment, prevention, and management of delirium. The second assessment tool is the Delirium Rating Scale. This tool is designed to detect some delirium symptoms, but not to measure symptom severity. The next is the ECHAMP Delirium Protocol. This offers practical tools physicians and nurses can use to help prevent and manage delirium. Last is the 4AT. This is a rapid assessment test for delirium and cognitive impairment. Nursing interventions include early assessment. Delirium champions are nurses who are particularly trained to prevent and/or reduce delirium by being proactive about identifying and modifying risk factors. Specifically, they focus on the administering assessments such as BCAM. Assess for orientation, disorganized speech, restlessness, lethargy, and decreased input and output. Administer BCAM, which is a brief confusion assessment method which just takes minutes to administer. Proactive geriatrics consultation for patients at risk for delirium. The consultation should be in place prior to surgery and through discharge. Direct patient-centered education. Research shows that patients with direct, individualized education experience lower risk of delirium, less anxiety, and shorter extubation. Education included a tour of the operating room, discussion about what to expect, and meeting the team beforehand. Non-pharmacological interventions can include early ambulation and range of motion exercises, sleep promotion, minimize lighting and noise between 10 p.m. and 6 a.m., avoid unnecessary night interventions like vital signs if medically acceptable, appropriate orientation, good lighting, visible calendar, a wall clock, and family visitations will help with this. Cognitive stimulation, have them play games, reminisce, read the newspaper, discuss current events, and listen to music. Fluid and electrolyte balance, encourage adequate hydration, open packaging for drinks if needed, and aids. Ensure the client has access to hearing or visual aids. Pharmacological interventions can include antipsychotics, typical and atypical, which include haloperidol, olanzapine, quetiapine, and risperidone, cholinesterase inhibitors, which include rivastigmine and donepezil, sleep aids, which include melatonin and ramelteon, and also sedatives. Delirium is identified as one of the leading postoperative complications for older adults. According to INWAY, postoperative delirium occurs in 5 to 50% of older adults after an operation. Considering that approximately 1/3 of the inpatient surgeries performed in the United States on individuals over the age of 65, proper care for delirium is crucial. Delirium is defined as an acute cognitive and attention decline resulting in sudden brain failure. Common complications of postoperative delirium described by INWAY include major postoperative complications, prolonged hospitalization, loss of functional independence, reduced cognitive function, and even death. Delirium presents itself in 3 different types. Ivignathine describes the first type as hyperactive, which is demonstrated by agitation and irritability, restlessness, and attempting to pull at tubes and lines and get out of bed. The second of these types is hypoactive, which is demonstrated as withdrawal, a decrease in responsiveness, flat affect, apathy, and lethargy. Lastly, the final type of delirium is considered a mixed type, which is the combination of both hyperactive and hypoactive delirium. Risk factors for delirium is characterized into 2 different categories called predisposing and precipitating. Predisposing risk factors are often non-modifiable, which includes, but not limited to, injury severity, pre-existing cognitive conditions such as dementia, chronic illness, and age and are usually present at admission. On the contrary, precipitating factors are often modifiable and usually present with the use of medications like benzodiazepines, the development of sepsis, lack of hydration, alteration in metabolic function, epileptic episodes, and head injury. These factors can potentially lead to other complications of delirium, such as malnourishment and electrolyte imbalances, possible aspiration pneumonia, pressure injuries, decreased mobility, falls, combative behavior, wandering, and long-term cognitive issues. Delirium is the most common complication of hospitalized older adults. In this presentation, we have identified risk factors of delirium, signs and symptoms to watch for, assessment tools to assess different levels of delirium, non-pharmacological and pharmacological interventions, as well as complications that can arise from delirium. Research has shown delirium can be prevented in about 1/3 of patients by using a multi-component intervention plan. This presentation allows people to have more knowledge about delirium, its causes, and ways to prevent it from occurring.